Welcome to Sleepy Science Odyssey. Tonight, dreams. The mysterious experiences that fill our sleeping hours, from vivid narratives that seem completely real to bizarre scenarios defying logic, from recurring dreams that visit us repeatedly to nightmares that wake us in fear, from lucid dreams where we know we're dreaming to the forgetting that erases most dreams upon waking. We'll explore what happens in the brain during dreaming, why we dream, what dreams might mean, how they relate to memory and emotion, and why understanding dreams matters for understanding consciousness itself. If you're new here, this channel is for people who need something to think about before they can stop thinking. Real sleep science and neuroscience, no exaggeration, just quiet facts in the dark. Let's begin. Most dreaming occurs during REM sleep, though dreams can occur during any sleep stage. The relationship between dreaming and sleep stages represents one of the fundamental discoveries of modern sleep science, revealing that our subjective experiences during sleep correlate with specific patterns of brain activity measurable through electroencephalography and other physiological monitoring. Understanding when dreams occur and how they vary across sleep stages provides insights into the neural basis of consciousness and the functions that dreaming might serve. Sleep consists of distinct stages that cycle throughout the night, each characterized by different patterns of brain electrical activity, muscle tone, and eye movements. The two major categories are non-rapid eye movement, or NREM sleep, further divided into three stages, N1, N2, and N3, and rapid eye movement, or REM sleep. A complete cycle from sleep onset through all stages and back typically lasts approximately 90 to 110 minutes, with 4 to 6 cycles occurring during a normal 8-hour sleep period. REM sleep is characterized by desynchronized, low-voltage, mixed-frequency brain activity resembling waking EEG patterns, rapid eye movements darting in various directions, and muscle atonia, near-complete paralysis of voluntary muscles, except the diaphragm and eye muscles. This paradoxical combination of brain activity, similar to waking with profound muscle paralysis, led early researchers to call REM sleep paradoxical sleep. REM periods occur cyclically throughout the night, with the first REM period appearing approximately 90 minutes after sleep onset and lasting only 5 to 10 minutes, while later REM periods last progressively longer, with the final REM period before waking potentially lasting 30 to 60 minutes. When people are awakened from REM sleep and asked if they were dreaming, approximately 80 to 90% report dreams, with reports typically being vivid, narrative, hallucinatory experiences involving visual imagery, apparent motion through dream environments, and emotional responses. The dreams reported from REM awakenings tend to be longer, more complex, more bizarre, and more emotionally intense than dreams reported from NREM sleep, though this difference is less absolute than originally believed. NREM sleep was initially thought to be largely devoid of dreaming, but systematic research revealed that dreams occur during NREM sleep as well, though with different characteristics. When awakened from NREM sleep, approximately 50 to 70% of people report mental activity, though these reports are often shorter, less vivid, less narrative, more thought-like, and more realistic than REM dreams. Stage N2 sleep, which comprises approximately 50% of total sleep time, produces dream reports in 50 to 60% of awakenings, while stage N3 or slow-wave sleep produces reports in approximately 30 to 40% of awakenings. The distinction between REM and NREM dreaming is not absolute, but rather a matter of degree. with REM dreams tending toward vivid, hallucinatory, bizarre narratives, while NREM dreams tend toward briefer, more thought-like, realistic mental experiences. However, vivid narrative dreams can occur during NREM sleep, particularly during the lighter N2 stage, and brief, fragmentary experiences can occur during REM sleep. This overlap suggests that dreaming may not be exclusively tied to specific sleep stages, but rather represents a dimension of mental activity that varies in intensity and character across sleep stages. The sleep onset period, the transition from waking to sleep during stage N1, produces distinctive mental experiences called hypnagogic hallucinations or imagery. These experiences often involve brief visual images, sounds, sensations of floating or falling, or sudden jerks called hypnic jerks or sleep starts. The imagery tends to be fragmentary and fleeting rather than forming coherent narratives, and people are often aware that they're transitioning to sleep. Similar experiences occurring during the transition from sleep to waking are called hypnopompic hallucinations. The discovery of REM sleep and its association with dreaming occurred in 1953 when Eugene Aserinsky and Nathaniel Kleitman observed regular periods of rapid eye movements during sleep and found that awakenings during these periods reliably produced dream reports. This discovery revolutionized sleep research by providing an objective marker for what had previously been considered purely subjective experiences. It suggested that dreams might serve biological functions rather than being epiphenomena or mere side effects of sleeping brains. The timing and duration of REM periods across the night follow predictable patterns. The first REM period is brief and follows approximately 90 minutes of NREM sleep. Subsequent REM periods occur at approximately 90-minute intervals, but last progressively longer. The proportion of REM sleep in each cycle increases across the night, so that the final cycle before waking may consist predominantly of REM sleep. This pattern means that most REM sleep, and therefore most vivid dreaming, occurs in the early morning hours, with the dreams closest to waking being the longest and potentially most memorable. The ratio of REM to NREM sleep also varies across the lifespan. Newborn infants spend approximately 50% of sleep time in REM sleep, called active sleep in infants, while adults spend approximately 20 to 25% in REM. This high proportion in infancy has led to hypotheses that REM sleep serves developmental functions, including brain maturation and learning. The proportion of REM sleep declines through childhood, stabilizes in adolescence and adulthood, and shows modest decline in elderly individuals, though considerable individual variation exists at all ages. The depth of sleep, the threshold of stimulation required to produce awakening, varies across sleep stages, with stage N3 slow-wave sleep representing the deepest sleep from which awakening is most difficult. Interestingly, REM sleep shows intermediate arousal thresholds despite the brain activation level resembling waking. This creates the paradox that we experience vivid dreams during REM sleep but may be difficult to awaken, and when awakened, we often remember dreams vividly. Conversely, we're easily awakened from N1 and N2 sleep, but may have little to report or quickly forget whatever mental activity occurred. Dream recall varies enormously among individuals, with some people recalling multiple dreams per night, while others recall dreams only occasionally or claim never to dream. This variation reflects multiple factors, including how often people awaken during or shortly after REM periods, Dream recall is highest when awakening occurs during or within minutes of REM sleep. Individual differences in dream salience or vividness, attention to dreams, and possibly differences in brain connectivity between regions involved in dreaming and regions involved in memory consolidation. The content of dreams varies across sleep stages and across the night. Dreams from the first REM period of the night tend to be less bizarre and more related to recent waking experiences than dreams from later REM periods. Early night NREM dreams, particularly from slow-wave sleep, sometimes incorporate recent learning experiences or replays of daytime activities. Late-night REM dreams tend to be the most bizarre and emotionally intense, with these being the dreams most likely to be remembered upon waking and reported as the dream I had last night. The neural basis of REM dreaming involves activation of specific brain regions and deactivation of others. Understanding which brain regions are active or inactive during REM sleep and dreaming reveals the neural architecture underlying dream experiences, explaining why dreams have their characteristic features, including vivid imagery, apparent reality despite bizarre content, emotional intensity, and poor memory consolidation. Modern neuroimaging techniques, including PET scans and fMRI, have mapped brain activity during REM sleep, revealing patterns that illuminate the dreaming mind. During REM sleep, brain metabolism and blood flow are as high or higher than during waking, concentrated in specific regions while reduced in others. The pattern of activation during REM sleep differs dramatically from both waking and NREM sleep, creating a distinct brain state associated with dreaming consciousness. This selective activation and deactivation of brain regions can account for many characteristic features of dream experiences. The limbic system, including the amygdala, hippocampus, and anterior cingulate cortex, shows high activation during REM sleep. The amygdala, crucial for processing emotions, particularly fear and threat, shows activity levels during REM sleep exceeding waking levels, potentially explaining the emotional intensity of dreams and the prevalence of anxiety and fear in dream content. The hippocampus, essential for memory formation and spatial navigation, is also highly active, possibly contributing to the combination of memory elements in dreams and the sense of moving through dream environments. Visual association cortices in the occipital and inferior temporal lobes show strong activation during REM sleep, consistent with the vivid visual imagery characterizing most dreams. Primary visual cortex, V1, shows less consistent activation, with some studies finding activation and others finding relative deactivation. This pattern suggests that dream imagery arises more from higher-level visual association areas, constructing images from memory and imagination, rather than from processing external visual input, explaining why dream imagery can be vivid despite closed eyes preventing visual input. The parietal cortex, involved in spatial processing and attention, shows variable activity during REM sleep, with some regions activated and others deactivated. The superior parietal lobule tends to be deactivated, while the precuneus often shows activation. This pattern may contribute to altered spatial awareness in dreams and the sense of embodied presence in dream environments despite the absence of actual sensory input regarding body position or movement. Motor cortices show activation during REM sleep despite the muscle atonia preventing actual movement. The supplementary motor area and premotor cortex, regions involved in planning and imagining movements, are particularly active, potentially generating the sense of moving and acting in dreams, even though the body remains still. This dissociation between motor planning and execution may contribute to occasional dream experiences of being unable to move or of moving in slow motion. The prefrontal cortex, particularly the dorsolateral prefrontal cortex, involved in executive functions, working memory, and logical reasoning, shows marked deactivation during REM sleep in most studies. This deactivation may explain several characteristic features of dreams, including acceptance of bizarre or impossible events without critical evaluation, poor working memory preventing recognition of inconsistencies, reduced self-awareness and metacognition, and difficulty maintaining coherent narrative threads. The sleeping brain essentially operates without full executive oversight, allowing dream scenarios to unfold without the reality testing that would immediately identify them as impossible during waking. The deactivation of dorsolateral prefrontal cortex during REM sleep contrasts with the activation of more ventromedial prefrontal regions, including the orbital and medial prefrontal cortex, which remain active or even show increased activity. These regions are involved in emotional processing, self-referential thinking, and default mode network activity. Their continued activation during REM sleep may contribute to the self-centered perspective of most dreams and the emotional engagement with dream content. The brain chemistry during REM sleep also differs dramatically from waking, with implications for dream phenomenology. Acetylcholine levels are very high during REM sleep, as high or higher than during waking, while monoaminergic neurotransmitters including norepinephrine, serotonin, and histamine are markedly reduced or essentially absent. This neurochemical profile, sometimes called REM on REM off modulation, is controlled by interacting populations of neurons in the brainstem, including cholinergic neurons in the pedunculopontine and laterodorsal tegmental nuclei that are active during REM sleep, and monoaminergic neurons in the locus coeruleus, dorsal raphe, and tuberomamillary nucleus that are silent during REM sleep. The high acetylcholine and low monoamines during REM sleep have multiple effects on brain function. Acetylcholine promotes cortical activation and plasticity while also modulating memory processes. The absence of norepinephrine may impair working memory and attention, contributing to poor critical thinking in dreams. The absence of serotonin may affect mood regulation and reality testing. The neurochemical state of REM sleep thus creates conditions conducive to vivid imagery and emotional experiences, while impairing the executive and metacognitive functions that would recognize dreams as unreal. The thalamus acts as a relay station for sensory information reaching the cortex, and during REM sleep, the thalamus shows activation patterns promoting internal rather than external processing. Thalamocortical connections remain active, but instead of relaying external sensory input, they appear to propagate internally generated activity patterns. This creates a situation where the cortex remains highly active and processes information as if receiving sensory input, but the information originates internally from memory and spontaneous neural activity rather than from the outside world. The basal forebrain, containing cholinergic neurons that project widely throughout the cortex, shows high activity during REM sleep, contributing to cortical activation and potentially to the hallucinatory quality of dream experiences. The activation of basal forebrain cholinergic systems during REM sleep resembles their activation during waking attention and learning, suggesting that REM sleep may represent a brain state optimized for internal information processing and memory consolidation, despite the subjective experience of dreaming. Pontine structures, including the pons, medulla, and midbrain, play crucial roles in generating and regulating REM sleep. The subliterodirsal nucleus in the pons, containing glutamatergic neurons, appears to be a key REM sleep generator, with activation of these neurons triggering REM sleep and deactivation terminating it. These neurons project to multiple targets, including motor neurons controlling eye movements, spinal inhibitory neurons producing muscle atonia, and ascending pathways modulating forebrain activity. The coordination of these projections creates the constellation of features characterizing REM sleep. The discovery of REM sleep atonia mechanisms illuminated both normal dreaming and pathological conditions. During REM sleep, neurons in the ventromedial medulla and subliterodirsal nucleus activate inhibitory neurons in the spinal cord that hyperpolarize motor neurons, preventing muscle contraction despite motor cortex activity. This protective paralysis prevents dream enactment, keeping us still despite dreaming of action. When this system fails, as in REM sleep behavior disorder, people physically act out dreams, sometimes resulting in injury to themselves or bed partners. The differences in brain activity between REM and NREM sleep help explain differences in dream characteristics. NREM sleep, particularly slow-wave sleep, shows different activation patterns with generally lower overall brain metabolism. More synchronized activity patterns with slow oscillations dominating the EEG, reduced limbic activation, contributing to less emotional dream content, and less deactivation of prefrontal cortex, potentially allowing more realistic and coherent thought-like experiences. The preserved prefrontal function during NREM sleep may explain why NREM dreams, though less frequent and vivid than REM dreams, tend to be more realistic and logical. Dream content reflects a complex mixture of recent experiences, emotional concerns, and memory consolidation processes. The content of dreams, the scenarios, characters, emotions, and events we experience while sleeping, has fascinated humans throughout history, with dream interpretation appearing in ancient texts and continuing in various forms today. Modern research has moved beyond symbolic interpretation to systematic analysis of dream content patterns, revealing that while dreams incorporate memory elements and emotional themes, they do so in ways that are often unpredictable and highly individual. The continuity hypothesis proposes that dream content reflects waking life concerns, activities, and preoccupations, with dreams providing a relatively continuous extension of waking consciousness, albeit in altered form. Supporting this hypothesis, content analysis studies find that dream characters often resemble people from the dreamer's life, dream settings often resemble familiar places, and dream activities often relate to the dreamer's daily concerns and interests. However, the relationship is not simple reproduction. Dreams transform waking experiences through condensation, displacement, and symbolism. Incorporation of recent waking experiences into dreams follows a characteristic temporal pattern with two peaks. The day residue effect describes the incorporation of events from the day or two immediately preceding the dream, with approximately 50 to 65% of dream reports containing elements traceable to experiences within the past 2 days. More surprising is the dream lag effect, where events from approximately 5 to 7 days before the dream appear with increased frequency. Events from the intermediate period, 3 to 4 days before, appear less frequently than would be expected by chance, creating a U-shaped temporal distribution. This temporal pattern may reflect memory consolidation processes, with the day residue effect capturing events still in working memory undergoing initial consolidation, while the dream lag effect captures events being integrated into long-term memory approximately 1 week after encoding. The reduced incorporation of 3 to 4 day-old memories might indicate a processing gap where memories have left working memory but haven't yet been fully consolidated into long-term storage. This pattern suggests dreams may play roles in memory processing rather than being random neural noise. Emotional experiences and concerns appear prominently in dreams, often in exaggerated or distorted forms. Threatening or anxiety-provoking content appears more frequently than positive content in most people's dreams, with the threat simulation theory proposing that this negative bias reflects evolved functions of dreaming in rehearsing responses to threats. The continuity hypothesis would predict that people experiencing stress, trauma, or emotional difficulties in waking life would show these concerns in their dreams, and indeed studies confirm that anxious individuals report more anxious dreams, depressed individuals report more negative dreams, and trauma survivors often experience nightmares related to their traumas. Dream characters, the people or beings appearing in dreams, provide windows into social cognition and relationships. Analysis of dream reports reveals that familiar people appear more often than strangers, with family members and friends being particularly common. However, character identification in dreams can be ambiguous, with dreamers sometimes knowing that a character represents a specific person despite the character not physically resembling them. Characters often behave in ways inconsistent with their real personalities, and composite characters combining features of multiple people occur regularly, suggesting that dream characters represent activations of social knowledge rather than accurate simulations of specific individuals. The self in dreams usually experiences dreams from a first-person perspective as the protagonist of dream narratives, but occasionally dreams occur from third-person perspectives where dreamers observe themselves as characters in scenes, or dreams shift between perspectives. The sense of agency, feeling in control of one's actions, varies in dreams, with some dreamers reporting active agency while others report feeling like passive observers of dream events. These variations in self-representation and agency may reflect different activation patterns in brain regions involved in self-awareness and motor planning. Bizarreness, the occurrence of impossible or highly improbable events, is a hallmark of dreams, though the degree of bizarreness varies across individuals and sleep stages. REM dreams tend to be more bizarre than NREM dreams, with bizarreness including impossible events like flying, sudden scene shifts with discontinuous transitions, character transformations, and violations of physical laws. Despite this bizarreness, dreamers typically accept impossible events without question during dreams, only recognizing impossibility upon waking. This acceptance of bizarreness reflects reduced critical reasoning due to deactivated dorsolateral prefrontal cortex during REM sleep. The specific content categories appearing in dreams have been systematically studied through content analysis systems, including the Hall and Van de Castle system, which codes dreams for characters, social interactions, activities, objects, settings, emotions, and descriptive elements. Analysis of thousands of dreams using such systems reveals patterns including more negative than positive emotions, more misfortunes than good fortunes, more aggression than friendliness in social interactions, and more indoor than outdoor settings. These norms vary somewhat across cultures and historical periods, but core patterns remain surprisingly consistent. Cultural variations in dream content suggest that while basic dream phenomenology is universal, specific content reflects cultural knowledge and concerns. People from different cultures dream about culture-specific objects, practices, and scenarios reflecting their waking experiences. Hunter-gatherer societies report more animal dreams than urban industrialized societies. Cultures that value dreams and discuss them frequently report higher dream recall and more elaborate dream narratives. These variations demonstrate that dreams, while biologically based, incorporate culturally shaped content and are influenced by cultural practices regarding dream sharing and interpretation. Recurrent dreams, dreams with repeated themes, scenarios, or content, occur in approximately 60 to 70% of people at some point in their lives. Common recurrent dream themes include being chased, falling, being unprepared for examinations or performances, teeth falling out, being naked in public, and being unable to run or scream. These themes often relate to common anxieties and stressors, with recurrent dreams potentially reflecting unresolved emotional concerns or ongoing stressors that the dreaming mind repeatedly processes. Nightmares, intensely disturbing dreams that often cause awakening, occur occasionally in most people but frequently in some. Approximately 85% of adults report at least one nightmare per year, while approximately 5% experience nightmares weekly. Nightmare frequency is associated with stress, trauma, anxiety, depression, and certain medications, including antidepressants, beta blockers, and drugs affecting dopamine or acetylcholine. Post-traumatic nightmares, which replay traumatic events with or without modification, represent a distinct category, often resisting the incorporation and transformation typical of normal dreaming. The incorporation of external stimuli into dreams has been tested experimentally through controlled presentation of sounds, lights, water sprays, and other stimuli during sleep. Results show that external stimuli are sometimes incorporated into dream content, often in transformed ways. A bell becoming a telephone, water spray becoming rain, a spoken name appearing in dialogue. However, incorporation is inconsistent and unpredictable, occurring in approximately 20 to 30% of stimulation events depending on stimulus intensity, sleep stage, and individual factors. The incorporation, when it occurs, typically transforms stimuli to fit ongoing dream narratives rather than creating accurate perceptions. Dream settings, the locations where dreams take place, most often resemble familiar places from waking life, including homes, schools, workplaces, and neighborhoods. But these familiar settings often contain bizarre modifications or combine elements from multiple locations. Completely unfamiliar or fantastic settings occur less frequently, but are more memorable when they do occur. The construction of dream settings appears to draw on spatial memories and mental maps, with the hippocampus's role in spatial processing during waking extending to constructing navigable environments in dreams. Dream recall varies enormously among individuals, and depends on multiple factors, including sleep stage, timing, and individual differences. The question of why we forget most dreams has puzzled researchers and dreamers alike. Given that we spend approximately 2 hours per night dreaming during REM sleep alone, yet most people recall perhaps one dream per week or less. Understanding the factors influencing dream recall illuminates both sleep neuroscience and memory processes, while providing practical insights for those wishing to remember dreams more reliably. The most powerful factor affecting dream recall is awakening during or shortly after REM sleep. When people are awakened within minutes of REM sleep ending, dream recall rates approach 90%, with detailed narratives often reported. As the interval between REM sleep and awakening increases, recall rates decline sharply, with recall rates dropping to approximately 50% after 10 minutes and continuing to decline with longer intervals. This rapid forgetting suggests that dream memories are fragile and require immediate attention or rehearsal to be retained. Morning awakenings naturally occur closer to the last REM period of the night, the longest REM period occurring in early morning hours, explaining why people most often remember dreams from just before waking. The dreams from earlier in the night, though equally experienced at the time, are usually forgotten unless awakenings occur during or shortly after them. People who wake frequently during the night may recall more dreams because they interrupt sleep closer to dream experiences, while people who sleep deeply through the night without interruptions may recall fewer dreams despite having them. The neurochemical state during REM sleep may contribute to poor dream memory consolidation. The absence of norepinephrine during REM sleep, while permitting vivid dreaming, may impair the memory consolidation processes that normally stabilize new memories. Norepinephrine release from the locus coeruleus during waking is important for memory consolidation, and its absence during REM sleep may create conditions where dream experiences are vividly lived but poorly encoded into long-term memory. Upon waking, norepinephrine levels increase rapidly, potentially enabling consolidation of dreams recalled immediately upon waking. Individual differences in dream recall are substantial and stable over time. High dream recallers, people who remember dreams several times per week, differ from low recallers in several ways, including increased awakening frequency during sleep, particularly during the second half of the night when REM periods are longest. Enhanced activity in the temporoparietal junction and medial prefrontal cortex during waking and during sleep, potentially reflecting greater attention to internal mental states. And personality factors, including greater openness to experience, interest in dreams, and possibly greater creativity. Brain imaging studies comparing high and low dream recallers reveal structural and functional differences. High recallers show greater gray matter density in the medial prefrontal cortex and increased functional connectivity between medial prefrontal cortex and other regions, including the temporoparietal junction. These regions are involved in attention, self-reference, and memory, suggesting that dream recall ability reflects individual differences in brain organization, affecting attention to internal experiences and memory encoding rather than differences in dreaming frequency or vividness. Gender differences in dream recall have been consistently reported, with women on average reporting slightly more dreams than men and reporting longer, more detailed dreams with more characters, emotions, and colors. These differences are modest and overlap considerably between genders, but they suggest possible influences of hormones, social factors including greater cultural permission for women to attend to and discuss dreams, or other biological or cultural factors. Gender differences in dream content also exist, with women reporting more indoor settings and familiar characters, while men report more outdoor settings, strangers, and physical aggression, though these differences have diminished in recent decades. Age affects dream recall, with children and adolescents often reporting high recall, young adults maintaining good recall, and elderly individuals showing declining recall with age. However, this pattern is variable, and some elderly individuals maintain excellent recall. The decline with age may reflect reduced REM sleep, reduced nighttime awakenings, reduced interest in dreams, or age-related changes in memory systems. Conversely, dream recall in children increases with age as verbal abilities develop, with very young children reporting simpler, briefer dreams and recall improving through childhood. Motivation and attention to dreams significantly affect recall. People who value dreams and pay attention to them recall more dreams than those who are indifferent. Keeping dream journals increases recall, likely through multiple mechanisms, including increased morning rehearsal of dreams, enhanced motivation, practice retrieving and recording dreams, and possibly changes in sleep patterns related to dream-focused intentions. The simple act of placing paper and pen beside the bed with intention to record dreams can increase recall, suggesting that expectation and readiness to attend to dreams influence their memorability. The technique of prospective memory, setting intentions before sleep, can enhance dream recall. People instructed to remember dreams before sleeping recall more dreams than those given no instructions, and the effect is stronger when instructions emphasize the importance and value of remembering. This suggests that pre-sleep mental sets influence what aspects of sleep experience receive attention and encoding, with intentions to remember dreams creating preparedness to notice and encode them upon waking. Dream salience, the emotional intensity, bizarreness, or personal relevance of dream content, affects recall. Emotionally intense dreams are more likely to be remembered than bland dreams, and bizarre or surprising dreams are more memorable than mundane ones. Nightmares are particularly well remembered due to their intense negative emotion and frequent awakening effect. This pattern parallels waking memory, where emotional and distinctive events are better remembered than neutral routine events, suggesting common mechanisms influence memory for both waking and dreaming experiences. Sleep disruption and fragmentation generally increase dream recall by increasing the probability of awakening during or near REM periods. Conditions that disrupt sleep, including insomnia, sleep apnea, medications, stress, and environmental factors, often increase dream recall despite reducing sleep quality. Conversely, medications that deepen sleep and reduce awakenings, including benzodiazepines and some antidepressants, often reduce dream recall even though REM sleep continues. This dissociation between REM sleep and dream recall demonstrates that recall depends not on dreaming per se, but on awakening patterns and memory consolidation processes. Selective serotonin reuptake inhibitors, or SSRIs, commonly prescribed antidepressants, often increase dream vividness and recall during the initial weeks of treatment, with some patients reporting intense, bizarre, or disturbing dreams. This effect typically diminishes with continued treatment. The mechanism may involve SSRI's effects on REM sleep architecture, increasing REM density, the frequency of eye movements during REM, and potentially intensifying dream experiences. Other medications affecting neurotransmitter systems can similarly influence dreaming and recall. Substances including alcohol, marijuana, and various drugs affect dream recall through effects on sleep architecture and neurochemistry. Alcohol suppresses REM sleep during the first half of the night, but leads to REM rebound in the second half, with potentially intense dreams. Chronic alcohol use disrupts sleep architecture, and alcohol withdrawal is associated with REM rebound and intense dreams or nightmares. Marijuana suppresses REM sleep during use, with vivid dreams upon cessation representing REM rebound. These substance effects demonstrate the importance of normal sleep architecture and neurochemistry for typical dream patterns. Lucid dreaming occurs when dreamers become aware they are dreaming while the dream continues. Lucid dreaming represents a remarkable alteration of consciousness, where the metacognitive insight that one is dreaming arises during sleep without awakening, creating a hybrid state combining features of sleeping and waking consciousness. Approximately 55% of people report experiencing at least one lucid dream in their lifetime, while approximately 20% report lucid dreams monthly or more frequently. Understanding lucid dreaming illuminates the neuroscience of consciousness, self-awareness, and volitional control. The defining feature of lucid dreaming is metacognitive awareness, recognizing that one is dreaming while the dream continues. This awareness can range from fleeting recognition quickly forgotten as the dream continues, to stable ongoing awareness maintained throughout the dream, to complete clarity about one's situation, including knowledge that one's physical body is asleep in bed. The degree of lucidity varies, with some lucid dreams involving only the recognition, "This is a dream," while others involve fuller metacognition, including reasoning about the dream state and intentional control over dream content. The ability to control dream content during lucid dreams varies considerably. Some lucid dreamers report ability to manipulate dream environments, summon characters, fly at will, or alter scenarios deliberately, while others report awareness of dreaming without volitional control. The degree of control appears to develop with practice, with experienced lucid dreamers reporting greater control than novices. However, even experienced lucid dreamers often report that dream control requires effort and sometimes fails, with the dream resisting attempts at manipulation or awareness fading back into non-lucid dreaming. Lucid dreams occur most frequently during REM sleep, though they can occur during sleep onset or NREM sleep. During REM lucid dreams, physiological measures remain largely typical of REM sleep: low muscle tone, rapid eye movements, high heart rate variability, but with distinctive brain activity patterns. Studies using EEG recording during verified lucid dreams reveal increased power in gamma frequencies, particularly in frontal regions, compared to non-lucid REM sleep. This increased gamma activity may reflect the enhanced metacognition and self-awareness characterizing lucid states. The frontal regions showing increased activation during lucid dreaming include areas that are typically deactivated during non-lucid REM sleep, particularly the dorsolateral prefrontal cortex and frontopolar cortex, involved in metacognition, working memory, and executive function. Functional imaging studies confirm increased activity in these regions during lucid compared to non-lucid REM sleep, suggesting that lucid dreaming represents a partial reactivation of prefrontal executive systems within the REM state. This reactivation allows critical thinking and self-awareness while maintaining the hallucinatory imagery and narratives of REM dreaming. Communication between lucid dreamers and researchers during dreams has been achieved through prearranged eye movement signals. Since eye movements are not paralyzed during REM sleep, lucid dreamers can execute volitional eye movement patterns, typically left-right movements, clearly distinguishable from random rapid eye movements of REM sleep, to signal that they are lucid. This technique, first demonstrated in the 1970s, provided objective verification that lucid dreaming is a genuine phenomenon occurring during verified REM sleep rather than being brief awakenings or confabulations. Using eye movement signaling, researchers have studied the timing of actions in lucid dreams compared to waking. Lucid dreamers instructed to perform tasks like counting or singing in dreams, and signaling the start and end times through eye movements show that estimated time intervals in dreams approximate real time, taking slightly longer than equivalent waking tasks. This suggests that time perception in dreams, despite subjective feelings that dreams unfold rapidly or that long durations occur instantly, actually proceeds at approximately normal rates, at least for consciously experienced intervals. Techniques for inducing lucid dreams have been developed and tested with varying success rates. Reality testing, the practice of regularly questioning during waking whether one is dreaming and testing reality through checks, like trying to push one's finger through one's palm, or reading text twice to see if it changes, aims to establish habits that carry over into dreams, triggering lucidity when reality checks fail in the dream state. Mnemonic induction of lucid dreams, or mild, involves waking after several hours of sleep and intending to recognize dreaming while visualizing becoming lucid, then returning to sleep. Wake back to bed, or WBTB, involves waking after approximately 5 to 6 hours of sleep, staying awake for a short period, typically 20 to 30 minutes to 2 hours, then returning to sleep with intention to become lucid. This technique exploits the high proportion of REM sleep in the final sleep cycles and the increased self-awareness during the brief waking period, which may carry over into subsequent REM sleep. Studies show WBTB combined with mild produces lucid dreams in approximately 40 to 50% of attempts, making it among the most reliable induction techniques. External stimulation during REM sleep has been tested as a lucid dream induction method. Flashing lights, sounds, vibrations, or other stimuli presented during REM sleep sometimes become incorporated into dreams, and if dreamers have been trained to recognize these stimuli as dream signs, they can trigger lucidity. Devices have been marketed that detect REM sleep through eye movement monitoring or other physiological signals and deliver stimulation intended to trigger lucidity. Success rates vary widely across individuals, with some people responding well and others finding the stimulation either ineffective or disruptive of sleep. Galantamine, a cholinesterase inhibitor that increases acetylcholine levels, has shown promise as a lucid dream induction aid when taken during the wake-back-to-bed waking period. Studies report that galantamine combined with WBTB significantly increases lucid dream frequency compared to placebo. The mechanism likely involves enhancing the already high cholinergic activity of REM sleep, potentially promoting the metacognitive awareness needed for lucidity. However, side effects can include nausea, headaches, and sleep disruption, and long-term safety for non-medical lucid dream induction use remains uncertain. The phenomenology of lucid dreams includes distinctive features beyond simple awareness of dreaming. Many lucid dreamers report heightened clarity and vividness compared to non-lucid dreams, with more vibrant colors, greater detail, and enhanced realism paradoxically accompanying the recognition of unreality. Emotional states often shift toward positive feelings, including exhilaration, wonder, and freedom, though anxiety about losing lucidity or waking can also occur. The sense of agency and self-awareness during lucid dreams resembles waking consciousness more than typical dreaming. Applications of lucid dreaming have been explored for multiple purposes. Nightmare treatment using lucid dreaming teaches patients to recognize nightmares as dreams and either wake themselves or alter nightmare content. Studies show that lucid dreaming techniques can reduce nightmare frequency and distress in some patients, particularly those with idiopathic nightmares rather than post-traumatic nightmares. Motor skill practice during lucid dreams has been tested based on findings that imagined movements during lucid dreams activate motor cortex similarly to actual movements, though whether lucid dream practice enhances skill acquisition remains unclear. Creative problem-solving and artistic inspiration have been pursued through lucid dreaming, with some individuals reporting insights, solutions, or creative works arising from lucid dream experiences. However, systematic evaluation is difficult, and anecdotal reports must be interpreted cautiously. The potential for lucid dreaming to provide unique creative states remains speculative though intriguing. Spiritual or philosophical exploration represents another motivation for pursuing lucid dreams, with some practitioners viewing lucid dreaming as a tool for self-exploration, psychological growth, or consciousness expansion. The relationship between lucid dreaming and meditation has been noted by multiple researchers and practitioners. Meditation practices that enhance metacognitive awareness and attention to mental states may facilitate lucid dreaming, and indeed practitioners of certain meditation traditions, including Tibetan Buddhist dream yoga, report high lucid dream frequencies. Conversely, the mental training involved in lucid dreaming practice may enhance metacognitive skills that transfer to waking consciousness. However, individual variation is substantial, with some people finding meditation facilitates lucid dreaming while others see no relationship. Potential risks of lucid dreaming include sleep disruption if excessive effort is invested in induction attempts, confusion between dreams and reality if lucid dreams are extremely vivid and memorable, and possibly psychological issues if individuals prefer dream experiences to waking life or use lucid dreaming to avoid waking problems. However, these risks appear minimal for most practitioners, and many people pursue lucid dreaming without negative consequences. The main limitation is that lucid dreaming remains difficult to achieve reliably for most people despite various techniques. Nightmares and disturbing dreams can reflect stress, trauma, and emotional processing. Nightmares, intensely disturbing dreams that typically cause awakening, represent the pathological extreme of normal dreaming, with content usually involving threats, danger, fear, or other intensely negative emotions. Understanding nightmares illuminates both normal dream function and the relationship between sleep, emotion, and mental health, while also informing therapeutic approaches for nightmare disorders and trauma-related sleep disturbances. The definition of nightmares typically requires several features: vivid and memorable dream content, dysphoric emotions usually including fear or anxiety, but sometimes disgust, sadness, or anger, coherent narrative structure with increasing threat or distress, and awakening from sleep, typically from REM sleep during the latter half of the night. Nightmares are distinguished from night terrors, sudden arousals from slow-wave sleep with intense fear but little dream recall, and from anxiety dreams that are disturbing but don't cause awakening. Nightmare frequency varies widely, with most adults experiencing occasional nightmares, but approximately 5% experiencing nightmares weekly or more frequently. Nightmare disorder, characterized by frequent nightmares causing significant distress or impairment, affects approximately 2 to 6% of the general population. Nightmare frequency is higher in children, with approximately 50% of children ages 3 to 6 experiencing nightmares frequently enough to disturb parents, though frequency typically declines through childhood and adolescence. Common nightmare themes include being chased or attacked, falling, being unable to run or scream despite danger, experiencing catastrophes including natural disasters or accidents, witnessing violence or death, and experiencing personal failure or humiliation. These themes often relate to evolutionary threats, predators, falling from heights, social exclusion, supporting theories that nightmare content may reflect ancient adaptive functions in simulating threats and rehearsing responses, though this interpretation remains debated. Trauma-related nightmares show distinctive features differing from ordinary nightmares. Post-traumatic nightmares often replay traumatic events with high fidelity, literal or near-literal reenactments of actual traumatic experiences, though some post-traumatic nightmares contain symbolic or transformed representations of trauma themes. Post-traumatic nightmares can occur during NREM sleep as well as REM sleep, distinguishing them from typical nightmares that occur predominantly during REM sleep. They often persist for months or years after trauma and may resist the normal tendency for dream content to drift away from recent experiences. Post-traumatic stress disorder, or PTSD, is strongly associated with nightmare disorder, with approximately 50 to 90% of PTSD patients experiencing recurrent nightmares related to their traumas. Nightmares are one of the defining symptoms of PTSD, along with intrusive daytime memories, hyperarousal, and avoidance behaviors. The persistence of trauma nightmares suggests that normal dream processes may be disrupted in PTSD, failing to integrate and transform traumatic memories in the way that normal dreaming appears to process emotional experiences. The fear extinction model proposes that REM dreaming normally functions to extinguish learned fear responses by reactivating fearful memories in contexts lacking the norepinephrine that promotes fear conditioning during waking. The absence of norepinephrine during REM sleep creates conditions favoring extinction, the gradual weakening of conditioned fear responses through repeated exposure without reinforcement. In PTSD, this process may be disrupted, with trauma memories being reactivated during sleep but failing to extinguish, instead causing repeated nightmare experiences that reinforce rather than reduce fear. Nightmare disorder in the absence of trauma, idiopathic nightmares, appears related to multiple risk factors including trait anxiety, neuroticism, thin boundaries between psychological states, stress, and possibly genetic vulnerability. People with frequent nightmares often show elevated anxiety and stress during waking, suggesting that nightmares may reflect ongoing emotional disturbances rather than being purely sleep phenomena. However, causation is unclear. Nightmares may result from anxiety, or recurrent nightmares may increase daytime anxiety, or both may result from shared underlying factors. Medications can cause or exacerbate nightmares. Beta blockers, including propranolol, used for hypertension and other conditions, frequently cause nightmares as side effects, likely through effects on norepinephrine in the brain. Antidepressants, including SSRIs and SNRIs, can increase dream vividness and sometimes cause nightmares, particularly during initial treatment periods. Dopaminergic medications used for Parkinson's disease can cause vivid dreams and nightmares. Withdrawal from alcohol, benzodiazepines, or other substances can trigger intense nightmares during REM rebound periods when REM sleep increases after being suppressed. Nightmare treatment approaches include both pharmacological and psychological interventions. Prazosin, an alpha-1 adrenergic antagonist that blocks norepinephrine receptors, has shown efficacy for trauma nightmares in some studies, though recent large trials have shown mixed results. The proposed mechanism involves reducing hyperarousal and excessive noradrenergic activity that may interfere with normal REM sleep processes. Other medications, including clonidine, gabapentin, and atypical antipsychotics, have been tried with variable success. Imagery rehearsal therapy, or IRT, represents the best established psychological treatment for nightmares. IRT involves recalling nightmares while awake, creating modified versions with changed endings or altered content that reduce threat or increase mastery, and mentally rehearsing the modified dream scenarios. Studies show that IRT reduces nightmare frequency and distress in both idiopathic nightmares and trauma-related nightmares, with effects maintained at follow-up months later. The mechanism may involve reducing nightmare-related anxiety, providing sense of control over dream content, or modifying memory representations that feed into nightmares. Exposure, relaxation, and rescripting therapy, or ERRT, combines elements of IRT with exposure to nightmare content and relaxation training. This more comprehensive approach shows similar or slightly better efficacy than IRT alone. Lucid dreaming therapy teaches nightmare sufferers to recognize nightmares as dreams while they occur and either wake themselves or alter nightmare content. Success rates vary, but some patients benefit from lucid dreaming approaches, particularly if they can achieve lucidity reliably. Sleep hygiene and stress management represent foundational approaches for nightmare reduction. Improving sleep quality through regular sleep schedules, appropriate sleep duration, and good sleep environments can reduce nightmares. Stress reduction through relaxation techniques, exercise, and addressing sources of daytime stress can also decrease nightmare frequency. For trauma-related nightmares, trauma-focused psychotherapies, including cognitive processing therapy and prolonged exposure therapy, which target PTSD broadly, often reduce nightmares as part of overall symptom improvement. The content of nightmares provides information about emotional concerns and possibly about psychological vulnerabilities. Content analysis reveals that nightmare themes often relate to current life stresses and conflicts, though in transformed rather than literal ways. Recurrent nightmare themes may point to ongoing unresolved emotional issues. However, attempts to interpret nightmare symbolism in specific ways, as Freudian or other symbol systems propose, lack empirical support. The relationship between nightmare content and waking concerns is real but complex and highly individual. Nightmare disorder can significantly impair quality of life through disrupted sleep, daytime fatigue, fear of sleeping, and emotional distress. Chronic nightmares are associated with elevated rates of depression, anxiety disorders, and suicide ideation, though whether nightmares contribute to these outcomes or simply co-occur with them remains unclear. The suffering caused by recurrent nightmares justifies clinical attention, and effective treatments exist, yet nightmares are often undertreated because patients don't mention them or clinicians don't ask about them. Cultural factors influence nightmare expression and interpretation. Some cultures attribute nightmares to supernatural causes, including spirits, demons, or soul loss, and employ cultural healing practices, including rituals, prayers, or traditional medicines. Western psychology's emphasis on internal psychological causes and evidence-based treatments represents one cultural framework among many for understanding nightmares. Cross-cultural studies reveal both universal nightmare themes, being chased, falling, disaster, and culture-specific elements reflecting particular beliefs, fears, and social structures. Dreams may serve important functions in memory consolidation, emotional regulation, and cognitive maintenance. The question of why we dream has occupied researchers and theorists for over a century, generating numerous hypotheses ranging from random activation theories proposing dreams as meaningless byproducts to sophisticated functional theories proposing critical roles in learning, emotion, creativity, and survival. While consensus remains elusive, accumulating evidence supports roles for dreaming in memory processing and emotional regulation. The memory consolidation hypothesis proposes that dreaming facilitates the stabilization and integration of memories, transforming recent experiences into long-term stored knowledge. This hypothesis is motivated by observations that REM sleep and dreaming increase following intensive learning, that dream content often incorporates recent learning experiences, and that REM sleep deprivation impairs certain types of memory consolidation. The hypothesis has evolved into more specific proposals about which aspects of memory benefit from dream-related processing. Procedural memory, memory for skills and procedures, including motor skills, perceptual skills, and cognitive skills, shows robust benefits from post-learning sleep, including REM sleep. Studies demonstrate that performance on motor skills, including finger tapping sequences and visual discrimination tasks, improves after sleep more than after equivalent waking intervals, with the improvement correlating with REM sleep amounts. Dream incorporation of practice tasks occurs sometimes, suggesting that the consolidation processes may involve replay or reactivation of task-related neural patterns. Declarative memory, memory for facts and events, shows more complex relationships with REM sleep and dreaming. Some studies find benefits of REM sleep for declarative memory, while others don't, with benefits appearing most reliably for emotionally salient material. The selective strengthening of emotional memories during REM sleep may reflect adaptive prioritization of emotionally important information while allowing less important details to fade. This selective consolidation could explain why we often remember emotional events vividly while forgetting mundane daily details. The emotional memory theory proposes that REM dreaming processes emotional experiences, extracting emotional meanings while reducing the intensity of emotional responses to memories. The high limbic activation combined with low norepinephrine during REM sleep may create ideal conditions for this emotional depotentiation, reactivating emotional memories in contexts that weaken their emotional charge. Supporting this theory, studies show that REM sleep reduces emotional reactivity to previously viewed emotional images, while REM deprivation maintains or increases emotional reactivity. The sleep to remember, sleep to forget framework proposes dual processing during sleep, strengthening important memories while weakening unimportant ones, extracting rules and patterns while discarding specific details, and maintaining emotional salience while reducing emotional reactivity. This framework suggests that sleep generally, and REM sleep specifically, performs complex memory triage, determining which aspects of experience to preserve, which to modify, and which to discard. Dreaming may reflect this sorting process, with dream content revealing which memories are being reactivated and processed. Threat simulation theory proposes that dreaming evolved to simulate threatening scenarios, allowing practice of threat perception and avoidance behaviors in safe dream contexts. This theory is supported by the prevalence of threatening content in dreams, the realistic simulation of threat scenarios despite bizarre elements, and the activation of brain regions involved in threat processing during REM sleep. Critics note that many dreams lack threatening content and that modern humans face different threats than ancestral humans, potentially limiting contemporary relevance of threat simulation. The proto-consciousness theory proposes that REM dreaming maintains basic consciousness capacities during sleep, exercising neural circuits supporting cognition, perception, and integration of information. This maintenance function would prevent degradation of consciousness capacities during the hours of sleep when external input is minimal. The theory suggests that the bizarre content of dreams is incidental to this maintenance function, arising as a byproduct of internally driven cortical activation patterns unconstrained by external reality. Activation synthesis theory, proposed by Alan Hobson and Robert McCarley in 1977, suggested that dreams result from the cortex attempting to synthesize coherent experiences from the random activation patterns arising from brainstem during REM sleep. This theory emphasized the bottom-up activation from pontine structures with cortical synthesis, creating dream narratives from this neural noise. While influential, activation synthesis theory has been criticized for understating the meaningfulness and organization of dream content, and for not accounting for NREM dreaming or the systematic relationships between dream content and waking concerns. The neuropsychoanalytic approach, associated with Mark Soames and others, proposes that dreaming reflects motivated processes driven by dopaminergic systems involved in seeking and reward, with dreams representing wish fulfillment as Freud proposed, but grounded in modern neuroscience. This approach notes that lesions to dopaminergic pathways can eliminate dreaming while preserving REM sleep, suggesting that REM sleep and dreaming are dissociable, and that dreaming depends on motivational systems. Critics argue that evidence for wish fulfillment in dreams remains weak, and that the approach overinterprets dream content. The default network hypothesis proposes that dreaming reflects activity of the default mode network, the set of brain regions active during wakeful rest and mind wandering. During REM sleep, default network regions including medial prefrontal cortex, posterior cingulate, and inferior parietal lobule show activation patterns resembling their activation during mind wandering. This suggests that dreaming may represent a form of unconstrained mental simulation similar to daydreaming, but occurring during sleep when external input and executive control are minimal. Empirical evidence relevant to dream function comes from multiple sources. REM sleep deprivation studies show that preventing REM sleep through awakenings impairs some cognitive and emotional functions, though effects are often subtle and some predicted deficits don't appear. Dream content analysis reveals systematic incorporation of recent experiences and emotional concerns, suggesting dreams are not random but reflect organized processing of waking content. Correlations between dream content and subsequent memory or mood suggest that what happens in dreams may influence waking outcomes, though causation remains difficult to establish. Individual differences in dreaming correlate with waking cognition and personality. People who dream more frequently or vividly show enhanced creativity, openness to experience, and sometimes enhanced memory. Whether these correlations reflect causal influences of dreaming on waking traits or simply shared underlying factors remains unclear. Experimental studies attempting to manipulate dream content to test effects on waking outcomes show mixed results, with some studies finding predicted effects while others don't, possibly reflecting methodological challenges in dream manipulation. Dream incorporation of learning tasks can be tested by training participants on tasks and examining whether task-related content appears in subsequent dreams. Studies using spatial navigation tasks, Tetris playing, and other paradigms find that task-related content appears in dreams in some participants, with the incorporation correlating with learning success. These findings suggest that dream incorporation reflects memory consolidation processes, with the memories being reactivated during sleep appearing in conscious dream experiences. However, much memory consolidation appears to occur without generating dream content, suggesting dreams may be epiphenomena of consolidation processes rather than the processes themselves. The function of NREM dreaming remains less studied and less theorized than REM dreaming. Given that NREM dreams are less vivid and more thought-like, they may serve different functions than REM dreams. Slow-wave sleep, when NREM dreaming occurs, is particularly important for declarative memory consolidation and synaptic downscaling. The less hallucinatory mental experiences during NREM sleep might reflect these processes, with the experiences arising from memory reactivation and synaptic modification occurring during slow oscillations characteristic of slow-wave sleep. Dream interpretation has ancient roots but limited scientific support for specific symbolic meanings. The impulse to find meaning in dreams appears universal across human cultures, with dream interpretation practices documented in ancient texts from Mesopotamia, Egypt, Greece, India, China, and indigenous cultures worldwide. While modern neuroscience has revealed much about the mechanisms of dreaming, the question of whether dreams contain meaningful messages or symbolism remains contentious, with scientific approaches emphasizing personal meaning and emotional salience while rejecting universal symbolic dictionaries. Ancient dream interpretation often involved symbolic correspondences where dream images represented specific predictions or meanings. The ancient Egyptians produced dream books listing dream symbols and their interpretations, typically involving predictions of future events. The ancient Greeks practiced dream incubation, sleeping in sacred temples to receive prophetic or healing dreams from gods. The Talmud discusses dream interpretation extensively, with rabbis offering interpretations based on symbolic principles. These ancient practices reflect beliefs that dreams convey messages from divine or supernatural sources, requiring expert interpretation. Sigmund Freud's The Interpretation of Dreams, published in 1900, revolutionized Western thinking about dreams by proposing psychological rather than supernatural meanings. Freud theorized that dreams represent disguised wish fulfillment, with unconscious desires expressed through symbolic transformations, including condensation, multiple elements combined into single images, displacement, emotional significance transferred from important to trivial elements, and symbolism, abstract concepts represented by concrete images. Freud proposed that dream interpretation could reveal unconscious conflicts and desires when symbols were decoded. Freudian dream interpretation relied heavily on symbolic associations, with certain symbols allegedly having universal meanings: elongated objects representing male genitals, containers representing female genitals, staircases representing sexual intercourse. These symbolic equations now appear simplistic and culturally biased, and empirical research has failed to support the universality of Freudian symbols. However, Freud's emphasis on dreams as meaningful psychological phenomena rather than random neural noise influenced subsequent dream research and therapy. Carl Jung proposed an alternative to Freudian interpretation, viewing dreams as communications from the unconscious that serve compensatory functions, balancing conscious attitudes with unconscious perspectives. Jung emphasized archetypal symbols, images appearing across cultures reflecting universal human experiences and evolutionary heritage, including the shadow, anima animus, and self. Jungian interpretation focuses on amplifying dream images through associations to mythology, religion, and cultural symbolism, rather than reducing them to sexual meanings. Contemporary psychodynamic dream interpretation has evolved beyond Freud and Jung, emphasizing collaboration between therapist and client in discovering personally meaningful interpretations, rather than applying predetermined symbolic dictionaries. This approach views dreams as creative expressions of emotional concerns, conflicts, and wishes that can provide insights into psychological functioning when explored respectfully and without rigid interpretive frameworks. Therapists using this approach attend to emotions, relationships, and themes in dreams rather than decoding symbols. Cognitive dream theories propose that dreams reflect the same cognitive processes operating during waking, including memory activation, problem-solving attempts, emotional processing, and simulation of scenarios. From this perspective, dream content is meaningful because it reveals current concerns, activated memories, and emotional states. But this meaningfulness doesn't require symbolic translation. Dreams can be understood relatively directly as expressions of cognitive processes. The bizarre and seemingly symbolic elements may reflect the peculiar constraints of dreaming cognition rather than disguise. The continuity hypothesis, mentioned earlier, proposes that dream content continues waking concerns into sleep, with dreams reflecting preoccupations, relationships, and activities from waking life. Research supporting this hypothesis shows systematic relationships between waking experiences and dream content, with recent events, emotional concerns, and ongoing activities appearing in dreams with predictable frequency. This suggests dreams are meaningful in that they reflect what matters to the dreamer, but the meaning is personal and contextual rather than based on universal symbols. Content analysis approaches to dream meaning employ systematic coding of dream elements and statistical analysis of patterns, seeking to identify meaningful themes and concerns objectively. The Hall and Van de Castle system and similar approaches provide reliable methods for quantifying dream content, allowing researchers to test hypotheses about dream meaning empirically. Studies using content analysis find that dream patterns relate to waking personality, emotional states, and life circumstances in interpretable ways, supporting the view that dreams contain meaningful information about dreamers' psychological functioning. Cultural and anthropological perspectives on dream meaning emphasize that dream interpretation is culturally constructed, with different cultures holding radically different beliefs about dreams and their significance. Some cultures view dreams as more real or important than waking life, with dreams providing access to spirit worlds or alternative realities. Other cultures view dreams as random neural activity without meaning. These variations demonstrate that dream interpretation practices are cultural phenomena shaped by beliefs, values, and social structures rather than universal truths. Spiritual and religious interpretations of dreams continue in many traditions, with dreams seen as communications from deities, ancestors, or spiritual forces. Islamic dream interpretation follows traditions derived from Quranic references to prophetic dreams. Hindu and Buddhist traditions incorporate dreams into spiritual practice and cosmology. Indigenous traditions worldwide include dream practices as integral to cultural and spiritual life. These interpretations provide meaning and guidance within their cultural contexts, regardless of whether neuroscience validates their metaphysical assumptions. The scientific consensus holds that while dreams are meaningful in reflecting emotional concerns, activated memories, and cognitive processes, there is no evidence for universal symbolic meanings or for prophetic or supernatural sources of dream content. Dreams appear to be products of the sleeping brain processing internal information according to its peculiar constraints, creating experiences that can reveal psychological states when examined appropriately, but that don't encode messages requiring decryption. Personal meaning can be found in dreams through reflection on their emotional tone, themes, and relationship to waking life. But this meaning is constructed through interpretation rather than decoded from symbols. Practical approaches to working with dreams emphasize personal exploration rather than expert interpretation. Keeping dream journals allows tracking of patterns and themes over time. Reflecting on emotions experienced in dreams can reveal current emotional states or concerns. Noticing recurrent dreams or themes may point to ongoing preoccupations or unresolved issues. Discussing dreams with therapists, friends, or in dream groups can provide new perspectives and insights. These practices don't require belief in symbolic meanings, but simply openness to dreams as psychological experiences worth attending to. The question of whether dream interpretation can be therapeutic has received some empirical attention. Studies find that discussing dreams in therapy is associated with therapeutic progress in some cases, particularly when dreams reveal emotional material not readily accessible through waking discussion. However, it remains unclear whether dreams provide unique therapeutic access or simply represent another route to the same emotional content available through other means. The therapeutic value may lie more in the reflective process than in the dreams themselves. Sleep disorders can profoundly affect dreaming experiences and dream-related behaviors. Various sleep disorders disrupt normal sleep architecture and dreaming, creating unusual dream experiences or problematic dream-related behaviors. Understanding these disorders illuminates normal dream mechanisms while also addressing significant clinical problems affecting quality of life and safety. REM sleep behavior disorder, or RBD, involves loss of the muscle atonia that normally prevents movement during REM sleep, allowing dream enactment. Patients with RBD physically act out dreams, sometimes violently, potentially injuring themselves or bed partners. Actions can include punching, kicking, leaping from bed, running, or shouting. Patients typically report that enacted dreams involve being attacked, chased, or threatened, with their dream actions representing self-defense or escape attempts. RBD occurs predominantly in older adults, particularly men over age 50, though it can occur at younger ages. Importantly, RBD is a strong predictor of future development of neurodegenerative diseases, including Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. Approximately 80 to 90% of idiopathic RBD patients, those without known underlying conditions, eventually develop Parkinsonian disorders, typically within 10 to 15 years of RBD onset. This relationship suggests that RBD represents an early marker of the neurodegenerative process affecting brainstem regions controlling REM atonia. Treatment of RBD involves both safety measures and medications. Safety measures include removing dangerous objects from bedrooms, padding floors, and sometimes sleeping in separate beds or rooms. Medications include clonazepam, which suppresses RBD in approximately 90% of patients with minimal side effects, and melatonin, which shows efficacy in many patients, particularly at higher doses of 6 to 12 milligrams. The mechanisms by which these medications suppress RBD remain incompletely understood, but may involve stabilizing REM sleep architecture and enhancing remaining REM atonia mechanisms. Narcolepsy, a disorder of sleep-wake regulation characterized by excessive daytime sleepiness and sudden sleep attacks, profoundly affects REM sleep and dreaming. Narcolepsy involves dysregulation of REM sleep processes, with REM sleep occurring at abnormal times, including immediately upon falling asleep, sleep-onset REM periods or SORMPs, and intruding into waking. Many narcolepsy patients experience cataplexy, sudden loss of muscle tone triggered by emotions, representing intrusions of REM atonia into waking. They also commonly experience sleep paralysis and hypnagogic-hypnopompic hallucinations. Sleep paralysis involves awakening from REM sleep before muscle atonia resolves, leaving the person conscious but unable to move. This can be terrifying, particularly when accompanied by hallucinations of presences in the room, pressure on the chest, or difficulty breathing. Sleep paralysis is common in narcolepsy, but also occurs occasionally in up to 40% of the general population. Episodes typically last seconds to minutes and resolve spontaneously, though they feel much longer to the experiencer. Understanding the phenomenon as a harmless timing mismatch between consciousness and muscle tone regulation can reduce associated distress. Dream content in narcolepsy may differ from normal dreaming. Some studies report increased dream vividness and bizarreness in narcolepsy patients, potentially reflecting the dysregulated REM sleep. The hypnagogic hallucinations occurring at sleep onset can be dreamlike, but often have distinctive qualities, including vivid imagery of faces or figures, auditory hallucinations, and sensations of presence. These experiences may represent REM dream phenomenology occurring at inappropriate times due to sleep-wake boundary instability. Nightmare disorder, discussed earlier, represents another sleep disorder centered on dreaming. When nightmares occur frequently enough to cause significant distress, impair functioning, or lead to sleep avoidance or sleep deprivation, they constitute a diagnosable disorder requiring treatment. Nightmare disorder can occur as a primary condition or secondary to other conditions including PTSD, depression, anxiety disorders, or medication effects. Sleep-disordered breathing, including obstructive sleep apnea, can affect dreaming indirectly through sleep fragmentation and hypoxemia. Apnea, cessation of breathing during sleep, causes arousals that fragment sleep and disrupt normal sleep architecture. Patients often report disturbing dreams involving suffocation, drowning, or being trapped, potentially reflecting incorporation of respiratory sensations into dream content. Treatment of sleep apnea with continuous positive airway pressure, or CPAP, often improves sleep architecture and reduces disturbing dreams along with resolving daytime symptoms. Insomnia, characterized by difficulty falling asleep, staying asleep, or poor sleep quality despite adequate opportunity for sleep, can affect dream recall and potentially dream characteristics. Insomnia patients who experience frequent awakenings may recall more dreams simply because they awaken during or shortly after REM periods. Some insomnia patients report that worrying about sleep or having anxiety-laden dreams about insomnia creates a vicious cycle where sleep anxiety disrupts sleep, which generates more sleep anxiety. Cognitive behavioral therapy for insomnia addresses these patterns along with other perpetuating factors. Klein-Levin syndrome, a rare disorder involving recurrent episodes of hypersomnia lasting days to weeks, affects dreaming during the hypersomnolent episodes. Patients may sleep 18 to 20 hours per day during episodes and report vivid, often bizarre dreams. The disorder predominantly affects adolescents and typically resolves spontaneously over years. The cause remains unknown, though hypotheses involve hypothalamic dysfunction affecting sleep-wake regulation and possibly altered neurotransmitter function affecting dream intensity. Parasomnias, abnormal behaviors emerging from sleep, include disorders beyond RBD. Confusional arousals, sleepwalking, and sleep terrors emerge from NREM sleep, particularly slow-wave sleep, rather than REM sleep. These parasomnias involve partial arousal where motor and autonomic systems activate while consciousness remains substantially impaired. Patients may have little or no dream recall associated with parasomnia episodes, though fragmentary imagery sometimes occurs. Sleepwalking and sleep terrors are common in childhood, affecting 10 to 30% of children at some point, with most outgrowing them by adolescence. Sleep-related eating disorder involves eating during partial arousals from sleep, with little or no memory of the episodes. Patients may eat unusual foods or combinations, sometimes consuming dangerous substances. The disorder can cause weight gain, shame, and medical complications. It appears related to both sleep disorders and eating disorders, sometimes responding to treatments for either category. Dream experiences during eating episodes are typically absent or fragmentary, suggesting impaired consciousness rather than dream-driven behavior. Exploding head syndrome involves hearing loud imagined noises, bangs, crashes, explosions when falling asleep or waking. Despite the disturbing name, the phenomenon is harmless, representing a benign parasomnia. It may reflect sudden activation of auditory neurons during sleep-wake transitions. No clear relationship to dreaming exists, though the auditory experiences might be considered a form of hypnagogic hypnopompic hallucination. Understanding the phenomenon as benign reduces anxiety that might otherwise develop from the startling experiences. Medication effects on sleep and dreaming can create unusual dream experiences or exacerbate sleep disorders. Beta blockers, antidepressants, dopaminergic medications, and many other drugs affect sleep architecture, dream intensity, dream recall, and nightmare frequency. Clinicians should routinely ask about sleep and dream changes when prescribing medications affecting the central nervous system. Sometimes adjusting dose timing, changing medications, or adding treatments for drug-induced sleep disturbances can resolve problematic effects while maintaining therapeutic benefits for the primary indication. Dreams occur throughout the animal kingdom, with REM-like sleep present in mammals and birds. The question of whether non-human animals dream has fascinated researchers and animal lovers, with implications for understanding consciousness, sleep functions, and the evolutionary origins of dreaming. While we cannot directly access animal subjective experiences, objective evidence, including behavioral and physiological observations, suggests that many animals experience REM sleep and possibly dreams. All mammals studied show REM sleep, with characteristic features including EEG desynchronization, rapid eye movements, muscle atonia, and physiological variability in heart rate and respiration. The proportion of sleep spent in REM varies across species, from approximately 5 to 10% in elephants and giraffes to approximately 40 to 50% in newborn humans, and other primates to even higher percentages in some small mammals. This variation may reflect different REM sleep functions across species or different developmental patterns. The behavioral manifestations of REM sleep in animals provide indirect evidence of dreaming. Dogs and cats during REM sleep show twitching of paws, facial movements, vocalizations, and sometimes coordinated movements resembling running or stalking, suggesting motor patterns related to dream scenarios. The movements are typically fragmentary rather than fully coordinated, consistent with muscle atonia preventing full dream enactment, as in RBD. Owners often interpret these movements as indicating dreams about running, hunting, or playing. Research with rats provides more direct evidence regarding dream content. Studies monitoring hippocampal activity while rats learn spatial navigation tasks, and later during sleep, find that firing patterns occurring during waking navigation replay during sleep, particularly during REM sleep. The replay is sequential and time-compressed, with the same neural ensembles firing in the same order as during waking but faster. This replay strongly suggests that rats are experiencing something like memory consolidation during sleep, possibly accompanied by dreamlike experiences of navigating previously explored environments. The specificity of sleep replay in rats is remarkable. Researchers can decode which specific trajectory through a maze the rat is replaying during sleep based on neural firing patterns, with accuracy levels demonstrating that very specific memories are being reactivated. Some replay occurs during NREM sleep as well, but REM replay shows distinctive features, including forward replay matching the original direction of navigation. Whether rats consciously experience these replays as dreams remains unknowable, but the similarity to proposed human memory consolidation during dreaming is striking. Birds show REM sleep with characteristics similar to mammals, including EEG desynchronization, reduced muscle tone, and periods of increased heart rate variability. Some bird species show vocal system activity during REM sleep that matches patterns occurring during singing while awake, suggesting that songbirds may dream about songs they're learning or have sung. This finding parallels motor skill consolidation during REM sleep in mammals, suggesting convergent evolution of REM sleep functions in birds and mammals. Zebra finches show particularly clear evidence of sleep-related song rehearsal. During learning of songs from tutors, young male zebra finches show neural activity patterns in song control brain regions during sleep that match patterns during singing while awake. The specificity is sufficient to identify which particular song elements the bird's brain is processing during sleep. This sleep-related activation may facilitate song learning, with the consolidation occurring during sleep supporting waking skill acquisition. Reptiles show sleep stages, but whether they exhibit true REM sleep remains controversial. Some studies report REM-like sleep in reptiles including turtles and iguanas, with brief periods showing EEG changes and eye movements suggestive of REM sleep. However, these periods are much shorter than in mammals or birds, lasting only seconds to minutes per day, if present at all. The evolutionary implications are unclear. REM sleep may have evolved before the divergence of reptiles, birds, and mammals, and been lost or reduced in reptiles, or it may have evolved independently in mammalian and avian lineages. Fish and amphibians show sleep or sleep-like states with reduced responsiveness and specific postures, but clear evidence for REM sleep is lacking. The absence of REM in these groups, if confirmed, suggests that REM sleep evolved relatively late in vertebrate evolution, possibly in conjunction with homeothermy, warm-bloodedness, and the associated energetic and neurological demands. Alternatively, REM sleep might exist in fish and amphibians, but with characteristics different from mammalian REM, making it difficult to identify with standard criteria. Invertebrates show sleep or sleep-like states in multiple groups including insects, crustaceans, and cephalopods. Fruit flies show behavioral sleep with features including reduced responsiveness, preferred resting locations, and homeostatic regulation with increased sleep following sleep deprivation. Bees show similar sleep behaviors. Whether these states include anything resembling REM sleep or dreaming remains uncertain, though recent observations of cuttlefish showing rapid eye movements and color changes during sleep have sparked speculation about dreamlike states in cephalopods. The octopus presents a particularly intriguing case for potential invertebrate dreaming. Octopuses are highly intelligent invertebrates with complex nervous systems containing approximately 500 million neurons, more than rats. They show sleep-like states with two distinct phases: quiet sleep with pale skin and little movement, and active sleep with rapid color and texture changes, eye movements, and muscle twitches. The active sleep phase, occupying only a few minutes per day, shows remarkable similarities to REM sleep, leading to speculation that octopuses may dream despite evolving intelligence independently of vertebrates. The evolutionary origins of REM sleep and dreaming remain mysterious. If REM sleep serves important functions like memory consolidation, emotional regulation, or brain development, its presence across mammals and birds suggests these functions were important enough to be strongly selected for during evolution. The high percentage of REM sleep in developing animals across species supports developmental functions, including synaptic refinement and neural network optimization. Adult functions may differ, with memory consolidation and emotional processing becoming more important. The convergent evolution of REM sleep in birds and mammals, assuming reptiles lack true REM sleep, indicating independent evolution in each lineage, suggests that the neurological substrates and ecological demands associated with warm-bloodedness, complex cognition, or other factors favored the evolution of similar sleep states. Alternatively, a REM-like state may have existed in a common ancestor with subsequent elaboration in mammalian and avian lineages. Resolving these evolutionary questions requires better understanding of sleep in reptiles, amphibians, and fish. The question of animal consciousness and whether animals subjectively experience dreams remains philosophical to a large extent. We cannot directly access animal experiences, and applying human concepts like consciousness or dreaming to non-human animals requires assumptions that may or may not be valid. However, the similarities in sleep architecture, neural activity patterns, and behaviors across species suggest that whatever functions sleep serves, including those involving REM sleep, are preserved across much of the animal kingdom, hinting at fundamental biological importance. If you're still awake somewhere in this exploration of dreams, of REM sleep and brain activation, of memory consolidation and emotional processing, of nightmares and lucid dreams, of animals replaying their days during sleep, there's more to discover about these mysterious experiences that fill a third of our lives. But if sleep has found you, if consciousness has faded into dreams, then rest knowing your brain continues its patient work of processing, consolidating, and making sense of the day you've lived. While you sleep tonight, your brain cycles through stages, each with its own characteristic activity patterns and mental experiences. During the first 90 minutes, you drift through light sleep into deep, slow-wave sleep, with mental activity becoming quieter and more fragmentary. Your brain generates slow oscillations, great synchronized waves of neural firing that may help consolidate memories from waking into long-term storage. The experiences during this period, if you have them, will likely be thought-like rather than dream-like, perhaps replaying scenes from the day or abstract mental activity without clear narrative. Later in the night, you enter REM sleep and hear the character of experience changes. Your brain becomes active as during waking, but the pattern of activation is unique. Visual areas active without visual input, limbic regions processing emotions without external cause, motor regions planning actions without muscular execution. The narratives that emerge from this peculiar brain state are dreams, vivid, emotional, bizarre, accepting of impossibilities that waking consciousness would immediately reject. The content of your dreams tonight will draw from today's experiences, from your ongoing concerns and relationships, from memories stretching back through your life, from emotions you may not have fully acknowledged while awake. The incorporation won't be simple reproduction, but rather transformation, elements condensed, characters morphed, scenarios shifted. You might dream about people you haven't thought of in years, triggered by some incidental similarity to someone you encountered today. You might dream scenarios symbolically related to current concerns, though the connection won't be obvious until you reflect on it after waking. You probably won't remember most of your dreams. The neurochemical state during REM sleep, with norepinephrine silent and acetylcholine flooding cortical circuits, creates conditions conducive to vivid experience, but not to memory consolidation. Upon waking, norepinephrine surges back, enabling the encoding of whatever dreams you recall in those first conscious moments. But the dreams from earlier in the night, experienced just as vividly at the time, fade without trace, their content irretrievable except perhaps in fragments triggered by random associations. If you experience nightmares, know that they represent the extreme end of normal dream processes, with emotional content intensified beyond comfortable levels. Occasional nightmares are normal, universal experiences, while frequent nightmares may signal stress, trauma, or other factors worth addressing. The same brain processes that make dreams possible, the activation of emotional and memory systems in the absence of executive oversight, create vulnerability to anxiety-laden scenarios that can wake us in fear or distress. If you become aware that you're dreaming, achieving lucidity, you enter a remarkable hybrid state, combining sleep's hallucinatory imagery with metacognitive awareness typically restricted to waking. The experience can be exhilarating, offering apparent freedom to explore and manipulate dream environments, or it can be unstable, with awareness flickering in and out as the dream continues. Lucid dreams remain uncommon for most people despite techniques for increasing their frequency, but those who experience them often find them memorable and meaningful. The functions that dreaming serves, while still debated, likely include contributions to memory consolidation, emotional processing, and perhaps cognitive maintenance. Your dreams tonight may be strengthening some memories while allowing others to fade, may be reducing the emotional intensity of difficult experiences while preserving their content, may be maintaining neural circuits supporting consciousness during the hours when external input is minimal. These functions proceed largely unconsciously, with dream content potentially reflecting the processing without being the processing itself. The fact that we spend approximately 2 hours per night, 6 years over a lifetime, experiencing dreams suggests that sleep serves purposes beyond simple rest. The elaborate neural machinery generating REM sleep, the precise coordination of brainstem, limbic, and cortical systems, the distinctive neurochemistry, all suggest that natural selection has shaped sleep architecture to serve important functions. Dreams may be incidental byproducts of these functional processes, or they may themselves contribute to the functions, or the truth may lie somewhere in between. Animals dream too, or at least experience REM sleep with similar neural and behavioral characteristics. Your dog dreams, twitching and whimpering during sleep in ways suggesting replays of running and playing. Rats dream of navigating mazes they've learned, with replays so precise that researchers can decode which specific trajectory is being reactivated. Songbirds dream of songs they're learning, with vocal control regions rehearsing patterns during sleep that support waking practice. The universality of REM sleep across mammals and birds suggests that whatever functions it serves are fundamental enough to be preserved by evolution over hundreds of millions of years. The mystery of consciousness during sleep, how vivid, coherent experiences arise from sleeping brains, why we accept bizarre impossibilities without question, why we forget most dreams upon waking, reflects deeper mysteries about consciousness itself. Dreams demonstrate that conscious experience doesn't require external input or accurate world modeling, but can arise from internal brain dynamics. They show that metacognition and critical reasoning are separable from vivid subjective experience, since we can experience intense dream realities without recognizing their impossibility. They reveal that memory consolidation and conscious awareness are distinct, since dreams can be intensely experienced yet poorly remembered. Consider, as you drift towards sleep or have already fallen, that the distinction between waking and dreaming is less absolute than it seems. Both states involve consciousness, both involve neural activity creating subjective experiences, both can include vivid imagery, coherent narratives, and emotional responses. The differences, dreaming's bizarreness, acceptance of impossibility, poor memory consolidation, reduced executive function, reflect changes in brain chemistry and activation patterns rather than fundamentally different kinds of consciousness. We are always experiencing consciousness, but the form it takes varies with brain state. The dreams you have tonight will be uniquely yours, reflecting your experiences, concerns, memories, and the particular activation patterns your brain generates during sleep. No one else will dream exactly what you dream, and you won't remember most of it come morning. But the experience will have occurred, the processing will have proceeded, the functions will have been served. Your sleeping brain continues its patient work of making sense of your life, consolidating what matters, processing emotions, maintaining the systems that support waking consciousness. And when you wake tomorrow, you may or may not remember the dreams, but the work they reflected will have been accomplished. See you next time.